Welcome to OAC Health Talks. I'm Joe Naglowski, President and CEO of the Obesity Action Coalition, and we are excited for you to join us for this educational series that dives deeper into specific health topics that we know are important to you and the OAC community. Health Talks are designed to empower you while providing straightforward, practical answers and insight from trusted experts. So let's dive into today's topic.
Hi, everyone. Thank you so much for joining us. We're going to be talking about something that's really exciting. My name is Dr. Andy Storm. We're joined by Dr. Mike Ujiki. I'm coming from the Mayo Clinic, where I lead the endoscopy group. Dr. Ujiki is a vice chair of clinical affairs for the Department of Surgery, also chair of innovation and program development at North Shore University Health System. We're really excited to be with you this evening, and we're going to talk about something that Dr. Ujiki and I meet about often, and this is specifically the topic of endobariatrics. Endobariatrics are a type of procedure aimed at combating obesity for our patients. These are non-surgical weight loss procedures done through the mouth or transorally. These procedures are fairly new, but we now have multiple FDA-approved options for our patients, and we'd like to talk through them with you tonight and then answer your questions after the seminar. Here are our disclosures. And I'd like to just chat briefly about what our learning objectives are today. Again, we'll introduce the fields of endobariatrics and metabolic endoscopy, and we'll talk through 3 different FDA-approved endoscopic options for weight loss, and we'll use some case examples or patient stories. These are stories that our patients have agreed we could share with other patients and folks who'd like to learn more about endoscopic bariatric techniques. As a bit of background, I think it's important for us to talk through the epidemic that faces our country and really our world. About 40% of the US is clinically obese by definitions based on body mass index, with a body mass index of over 30. This disproportionately affects minorities. Nearly half of African Americans and Hispanic people here in the United States do suffer with obesity. It's associated with increased mortality from COVID-19. It's associated with the metabolic syndrome, which leads to issues like type 2 diabetes, needing to inject insulin, liver disease like fatty liver disease that can lead to cirrhosis. Also vascular disease, heart attack and stroke that's clearly associated with obesity. Also many different types of cancer that have been associated with having obesity, and then psychiatric illness as well. So this is clearly something we're all motivated as physicians to help our patients with. What options do we have available to us? I'm showing here a picture of my grandfather, who was a primary care physician in Chambersburg, Pennsylvania. There he took care of a whole range of ages as a family practice doctor, and here he was in his local newspaper giving the first oral polio vaccine to the first child in Chambersburg, Pennsylvania, to receive this vaccine. And at the time, this is what was concerning to pediatricians and doctors, was to prevent communicable disease, infections like polio. And so that was clearly the focus of our national and public health systems. Now we have a new problem. Obesity has tripled in our patients, in our young patients, in pediatric cases over the last 4 decades. It is by far the #1 pediatric nutritional disorder worldwide. When I quiz our medical students and other folks, everyone always guesses that worldwide the #1 pediatric nutritional disorder is starvation or malnutrition. It's not at all. It's now become obesity, which should catch our attention. Finally, I'll say that diseases that were never seen in children during my grandfather's time as a physician are now emerging. So obesity-associated sleep apnea, one of our patients needing to use a device to help them breathe overnight in their young childhood. This is something that didn't exist 20 years ago. Non-alcoholic fatty liver disease and cirrhosis. We're actually doing liver transplants now for children at Mayo Clinic who suffer from cirrhosis and end-stage liver disease due to obesity. So this is clearly something that needs our attention. Type 2 diabetes, something that didn't exist in children in the past. So I don't want you to take it from me. We should also consult our experts, and I'll turn it over to Dr. Ujiki, who's going to talk through some of the history and background on surgery for obesity.
Yeah, thank you, Andy. You've set the stage very well. There's no question that obesity has really become a major epidemic and a major problem, not just in the US, but also worldwide. And we've had great treatments for obesity for really decades. Actually, in the 1960s, gastric bypass was a surgery that was invented actually for reflux disease. Um, Over time, though, physicians recognize and surgeons recognize that people were also losing weight. And it's now become more known for a weight loss procedure than for treating reflux disease because it has excellent outcomes. Um, we actually have improved the procedures over the last few decades to the point where the complication rate or morbidity is really no different than outpatient gallbladder surgery. About 2% of patients have complications. Um, Very few people would ever die from the procedure. There's no question we see more people die from obesity than we do from the procedures to treat these. And so over the years, these surgeries have become more refined. They're less invasive. Uh, we get patients in and out of the hospital quickly, and we have excellent surgical outcomes. There have been multiple studies that have shown that if patients qualify for surgery, weight loss surgery, and they have it, and you compare them to those that qualify for surgery that don't have it, patients that have surgery wind up living longer, they have a better quality of life, and they have less of all the diseases that Andy just talked about, less cancer in particular, less cardiovascular diseases, things like stroke and heart attack. So we've got excellent treatments for obesity. But interestingly, very few people that qualify for surgery are opting for surgery. As a matter of fact, less than 1% of patients in the United States that are eligible for surgery actually have bariatric surgery. That's incredible. 99% of patients who qualify for weight loss surgery, a surgery that would actually help them live longer, have a better quality of life, and prevent or treat diseases that they have, are actually having surgery. And there's a whole host of reasons for this. I think number one, there's a perception out there that surgery is not safe, which is untrue. Um, and that perception is not just from patients, but actually even from other physicians, non-surgeons. And there have been multiple studies that have shown, number one, that our own physicians don't always know exactly when we should be referring patients for surgery. And when we ask them why, when we survey these primary care physicians, a lot of them feel that there are concerns over complications, and a lot of them are just lack familiarity with the available options. And as Andy has mentioned, we're going to be talking about less and less invasive options. Surgery is not the same as it was 10 years ago, 15 years ago, or 20 years ago. It's getting better and better. So we have to change that perception. But I also think that we can make surgery or procedures for obesity even less invasive itself. And so here now we're going to talk about procedures that fill this gap. You know, we have obviously diet and exercise, which we should all start with. But interestingly, only about 10% of patients can achieve about 10% weight loss through diet and exercise. And so that's a very small number of patients that are able to achieve that. And there are multiple reasons for that. Some are environmental, but the bottom line is that diet and exercise alone is going to work for a minority of patients. And then I just mentioned we have great surgical options, but less than 1% of patients are actually opting for those. So we do need something that kind of fills this gap in between, and procedures that are less invasive, that are safe, that have good outcomes. And that's where we come up with endobariatrics. Very exciting field over the last 10 years that has grown exponentially. And it's grown because both patients and physicians have recognized that we have some really great outcomes, very safe outcomes with endobariatric procedures. And I'm going to turn it back to Andy to go over some of those.
Thanks, Mike. Yeah, so endobariatrics we define as a through-the-mouth, non-surgical approach to weight loss and revision after bariatric surgery interventions for weight loss. So I think of these procedures kind of like a colonoscopy, meaning we're using a natural orifice, a natural opening into the body to then achieve a procedure, some outcome that's needed. So this is very much like an upper endoscopy or a colonoscopy if you or a loved one has been through that type of procedure. These are outpatient procedures, so these are performed in outpatient centers and hospitals with the intent that our patients will go home the same day. So generally speaking, an endobariatric procedure is meant to be an outpatient procedure where one would go home the same day as the procedure. The goal of these procedures is to lose 10%, but frankly more than that, hopefully 15, sometimes 20% of total body weight, knowing that at that 10% total body weight loss, particularly if it's maintained for a longer period of time, there are very clear, very good health benefits, including a reduction in what we call macrovascular disease, that's heart attack and stroke, but also other issues like type 2 diabetes and fatty liver disease, if we can achieve that 10% total body weight loss or more. So fortunately, that's something our field has set as a bare minimum goal. No therapy has been approved or can be approved, which is not going to at least meet that threshold. So the first patient I'd like to chat about, this was a 48-year-old woman. She was a patient of mine who underwent a Roux-en-Y gastric bypass surgery 8 years previously. She had obesity and type 2 diabetes. Her weight loss was great after her Roux-en-Y gastric bypass, but she experienced weight recurrence, taking her on a road trip from being 350 pounds to 190 pounds. Wonderful outcome. Her diabetes had melted away. She was really doing great. And then over time, which is the nature of having a disease like obesity, it is a chronic, relapsing, remitting disease that requires many different tools and a whole lifetime of working against it, like type 2 diabetes. Her weight recurred and brought her back to about 250 pounds. And this brought back her joint pain. This brought back high blood sugars. She was headed back towards having to restart medications for type 2 diabetes. And so she asked, what options do I have that would not require having another surgery? Acknowledging that the risk of a second and third surgery is somewhat higher than the first surgery, which tends to be very safe, again, as Dr. Ujiki had mentioned. So this is a procedure, and something that was discovered is that the opening between the gastric pouch and the small intestine will stretch over time. Our tissues are kind of elastic, and that's just a normal thing that happens. So of no fault of her own, this opening between the pouch, the stomach pouch, and the small intestine created in a gastric bypass had stretched over time. And so this procedure, you can see here, it's a little bit in a fast forward. It's a little jumpy, and I apologize for that about the video, but this is called the TORI procedure, or endoscopic revision procedure. This is one of those endobariatric procedures that's FDA approved. It's something that I did today twice for 2 of my patients. This is a procedure performed every day, many, many times across the country. And this is to revise and help tune up a previous surgery, a previous weight loss surgery that worked well, but is now starting to slip. And that's something that can happen in some percentage of patients over time. And so here we've done a little bit of cautery. That's why the stomach tissue looks a little bit like a nicely cooked marshmallow in one area. And then we've worked our way around that anastomosis in a full 360 degrees. Here we're inflating a balloon. This allows us to size, to take down or reduce the size of this opening over the balloon. We can pick and choose the size. And then through endoscopic suturing, again, this is all done through the patient's mouth. Here we're in the gastric pouch, and we're able to reduce the size of that opening really nicely. And you can see here we've taken it from 30 millimeters down to 6 millimeters. It's a significant drop in size of the anastomosis. And then we can also do a little bit of suturing in the gastric pouch to help reduce the size there as well. So the TORI, or revised procedure, FDA approved. It's an outpatient procedure. I do this many times a week here at Mayo Clinic. It's also performed at most academic centers across the country. It can be performed after a surgical or laparoscopic sleeve, or after a Roux-en-Y gastric bypass, where our patients are experiencing weight recurrence or dumping syndrome after a gastric bypass. The recovery time is about 2 or 3 days at home, and then we get our patients usually back to work just after that. It does require a 6-week liquid diet. So in order to allow this to heal nice and tight, for that bridging scar tissue to form right where we put it with the sutures, it takes about 4 to 6 weeks being on a liquid diet, a little longer than our patients maybe remember from their original gastric bypass surgery. And then typical weight loss is at least 10%, often much more than that. Again, it depends on individual situation and what type of surgery we're starting off from. So this is a great procedure, again, for folks who've already had a bariatric surgery but are experiencing weight recurrence and need to have a tune-up. Very nice insurance-covered procedure that we, again, offer regularly. The second patient that I'd like to share with you, this is a retired police officer from Boston. He was very happy for me to share this with patients and other physicians. He had a familial end-stage heart failure disease, and so he, again, of no fault of his own, had developed heart failure. Because of his heart failure, huffing and puffing when he tried to do exercise, he just could not lose weight. And in order to qualify for a heart transplant in the United States, there are very strict criteria around controlling the hemoglobin A1C, which is a measure of diabetes control. Also a weight requirement for patients who want to qualify for a heart transplant. So the only way he was going to survive in the long term was to have a heart transplant. He needed to lose weight, but was not able to exercise because of that heart failure. To me, it feels really unfair. And so at the time, because of his blood thinners, he did not qualify for a surgery, some of which Dr. Ujiki had mentioned. It was felt to be too high risk for him to go through a full bariatric type surgery. And so he did qualify for a new device. This is the endoscopic gastric balloon or intragastric balloon. Our goals were to get him down below a body mass index of 35 and a hemoglobin A1C percent of 7.5. And so he had this balloon placed. It's done under an anesthetic, so patients are asleep and comfortable. The balloon is introduced down into the stomach under endoscopic guidance. So here we traveled through the patient's esophagus. You can see the balloon coming out into the stomach here. The stomach for all of us is about a football-shaped tube that holds our food. And then here we're showing outside of a patient how the balloon can be filled with fluid. This is a device that my patients tell me feels like having a full grapefruit sitting in your stomach for 6 to 12 months. And so this device is left in place, again, for up to a year. Depending on the device, it can be a different duration of time, but it sits there, it blocks the exit from the stomach, and it helps patients lose weight, basically by consuming less calories, blocking the exit of the stomach, helping people to feel full longer. And so purely through that mechanism, our patient had great success. We can see here that he had the intragastric balloon or IGB placed. When I first met him, he was about 6 months into his evaluation for heart transplant. After that balloon was placed, he lost weight rapidly. We can also see the dotted line is his fasting serum glucose, or a measure of his blood glucose. So his diabetes improved rapidly, his weight improved rapidly. He actually had a left ventricular assist device, or a device that's implanted in the belly to help the heart continue pumping appropriately through his course. So that was safe to have in place with this balloon. The balloon was then retrieved after 6 months, and he got his heart transplant because he was below our goals of both body mass and fasting or A1C percent. He had his heart transplant, and I'm happy to say he is doing well now. This was about 5 years ago. So really happy story for that patient. And then the final patient who I'd like to share with you is someone I work with here at Mayo. And she, again, is very happy for me to share her story with other patients and folks who are interested in learning about these procedures. But she's 38. Her BMI was 38, and her obesity complicated her ability to live life as she wanted to, which is that she wanted to have a child. And so her fertility physicians, her obstetrician, shared with her that she needed to lose weight in order to become fertile, to be able to have a child. She actually failed in vitro fertilization 3 different times. She did not want to have a traditional bariatric surgery. She was just averse to having that, despite my encouragement to proceed with something like a surgery. But she was willing to consider some endoscopic or through-the-mouth procedures for weight loss. And so this brings us to our third and final FDA-approved available procedure. This is called the endoscopic sleeve gastroplasty, or ESG. The ESG takes the stomach, and this is my view using a gastroscope or a camera on the end of a long flexible tube, sitting down at the beginning of the stomach. We're looking down into that football, basically, the stomach. This is my view of a normal, healthy stomach on the left. We use that suturing tool that I had talked about to then create a sleeve. So we fold the stomach in on itself. This is, again, all done while a patient is asleep over the course of about 45 minutes to an hour. And then the end result is something that looks a lot like a surgical sleeve on the inside, only instead of removing a portion of the stomach is imbricated or folded in upon itself. And on the right, this is that same stomach after an endoscopic sleeve gastroplasty ESG procedure. So again, using live patient video, this is an ESG procedure. Again, a normal, healthy stomach. Here our scope is turned around and looking back on itself as it comes from the esophagus. This is the pylorus, or exit to the stomach. This is the valve that helps control release of food from our stomach down into the small intestine to be absorbed. You can see the stomach is a pretty large organ, so it can expand. We pump in carbon dioxide gas to help us see the size of the stomach. And then we'll start our suturing here. So this is a corkscrew device that's used during that endoscopic sleeve gastroplasty to pull tissue into the suturing tool. We can fold that tissue in, and then we'll take bites in series. We'll pass the suture. It's kind of like a sewing machine for anyone who's a seamstress at home. This allows us to pass a suture through that tissue. It goes through the entire thickness of the stomach, both through the mucosa or inner lining to the serosa or outer lining of the stomach. And you can see here, this is one of several dozen bites that we'll take in the stomach that allows us again to fold the stomach in upon itself. And I'll skip forward just a little bit in the video. Here you can see the stomach again is starting to crunch down and close as we pull this suture tight. Takes about 6 to maybe up to 10 sutures in series that are placed to reduce the size of the stomach, again aimed at reducing the volume of the stomach by about 70 to 90%. And that allows the banana-sized stomach, instead of being football, banana-sized, to not accommodate as much food. It reduces what it takes for us to feel full at mealtime, and helps patients lose weight through that, both delayed gastric emptying and also that sense of fullness and satiety, or feeling like we've had enough at mealtime. So that's the endoscopic sleeve gastroplasty. Wonderful data available, so we can counsel our patients here and across the country that the goal is to lose about 15 to 16% total body weight with this procedure. Many of our patients lose much more, sometimes 20 or 25%, but the range and average in our meta-analysis here was that we expect patients to lose at least 16% of their total body weight. One issue that's come up as we speak with insurance companies about covering these procedures, some have tried to recommend that it's important that patients pay for part of their procedure and that they have what's called skin in the game. This has been disproven. So our surgical colleagues, Dr. Ujiki and others, have shown that that's clearly not necessary. That's clearly not true. Surgical outcomes for patients with obesity are just as good whether or not insurance covers the procedure. That is to say, there should be no requirement that patients pay out of pocket for these procedures, and that's our end goal. We're working with our industry partners at very different companies who offer these devices and procedures along with us. We're working with insurance providers. We're working with our own institutions to make sure that these are procedures that are covered. The Obesity Action Coalition, another really important factor in giving us an opportunity to speak with you, but also in pushing towards helping folks understand the data, which is that there is no difference in outcome with out-of-pocket payments. This is something that we have to offer to patients, and our society just simply should not require that patients have skin in the game when it comes to these life-saving treatments like endobariatric procedures and bariatric surgery across the board. I'll turn it back to my colleague, Dr. Ujiki, to talk through some of what he sees as a surgeon, endobariatrics being. Mike?
Yeah, thank you, Andy. Those are great cases. And I think these are cases that we see every day. And I think, again, having other options, having as many tools in our toolbox to treat a very difficult disease like obesity is making it better and better. I had a patient tell me that he really felt that fighting obesity was this war that he was fighting with a stick his whole life. But once he had a procedure done, he felt like he was now fighting that war with a tank. And he just said we really felt like we were equipping him with the ability to withstand the terrible disease that obesity is. And when we started doing endoscopic sleeve procedure as well as a Tori procedure well over 10 years ago, one concern that I had as a surgeon is, would I be burning a bridge? For example, if I did the endoscopic sleeve and it turned out that, 3 years later, 5 years later, 10 years later, there was weight recurrence, would I make it more difficult than to do surgery? What we have found, and not only us here at North Shore in Chicago, but other people have authored papers where they have shown that if you go back with a patient who has weight recurrence, who now wants maybe more of an invasive procedure like a surgical procedure, you can do that even after an endoscopic sleeve, as Andy just showed. And so that made us very happy, because now I feel like very confident that I can offer a surgical procedure if the patient wants, but also an endoscopic procedure if the patient wants. And it's a very common question that patients have. If I do an endoscopic sleeve, am I going to not ever be able to do a laparoscopic sleeve or a surgical sleeve or a bypass, for example, in the future? And the answer simply is no, you don't burn any bridges at all. You absolutely can. And I think that's made us feel very confident that the endoscopic procedures are here to stay and will, not burn any bridges. And speaking of bridges, so some of you may have heard about the Choluteca Bridge, but I think that this is very applicable to what we're talking about today. If you haven't heard about it, this is a bridge that was built in Honduras, and it was built for one reason. Number one, in Honduras, every year there are significant weather issues that wipe out bridges. For example, very bad hurricanes, category 3, 4, 5 hurricanes, and that wipe out the bridges when they come through. And when the bridges are gone and trucks cannot move through the country, the economy completely would shut down. And so the U.S. Army Corps of Engineers was tasked with building a bridge that could withstand any hurricane. And indeed, they built the Choluteca Bridge, and it was a success. It was a bridge that basically was strong enough to withstand Hurricane Mitch, which you may or may not remember, but Hurricane Mitch was a Category 5 hurricane that came through and wiped out every single bridge in the Honduras except for the Choluteca Bridge. So in many ways, we succeeded at building this very strong bridge. The problem was that the storm was so strong, and you can go to the next slide, that it basically moved the river that the bridge was over. And I think the lesson here is that that bridge is our bariatric treatments. These are our weight loss surgeries. Our weight loss surgeries are outstanding. They're the best they've ever been. They're the most durable that they've ever been. They're the safest they've ever been. But the environment has changed. Physicians and patients want even less invasive procedures, like procedures that have no incisions, endoscopic procedures that lose almost as much weight loss as some of our surgical procedures, but yet with a outpatient procedure, home same day, back to work in a couple days, with a safety profile that's even better than what we've built. So I think that this is a really applicable analogy and story to what we're seeing right now with weight loss treatments and weight loss surgery. And I have to tell you that I've actually experienced some of this personally myself, and my wife has allowed me to share this, but that's my wife and my 2 kids. And this is the day that my wife just came back from the hospital just over a year ago. Very healthy, has been healthy her whole life. Woke up with a bad headache. And wound up going to the emergency room, and unfortunately was found to have a ruptured aneurysm, a cerebral aneurysm. And when I did my surgical training and I did my neurosurgery rotation, a ruptured cerebral aneurysm was a large incision on the head. It was called a craniotomy. We'd have to go through the skull and then control the bleeding from the aneurysm. And patients literally would take months to years to recover from something like that. Well, the neurosurgeon that took care of my wife went through an artery in her wrist and was able to both coil and stent that aneurysm. And the very next day, she was completely normal. And so this is something that I would not have ever expected to happen based on what I saw 20 years ago when I did my neurosurgery rotation. And seeing just what those advancements of going from more invasive procedures to completely non-invasive procedures is something that I've lived through, and fortunately to this day she's completely back to normal, and I'm very grateful for the innovations that were made in neurosurgery, and I really think that patients who are suffering from obesity will really feel happy with the innovations that we've now made with bariatrics. So I'll conclude. I think Andy's done a great job of really laying out what endobariatrics is. I think that he pointed out that obesity care is expanding to all fields. So it's not just medicine, it's not just surgery, but now we have endoscopic treatments and procedures that are very attractive. They're safe, they're repeatable. These are procedures that can easily be combined with other treatments like surgery, for example, in the future, or with medications. These are low-cost procedures. Patients are in and out of the hospital same day. There's minimal complications. And these procedures are now approved by the FDA. He mentioned the revision of procedures. So, for example, patients that have had a previous weight loss procedure like a gastric bypass, a sleeve gastrectomy, a loop duodenal switch, for example. If there is any weight recurrence, patients can undergo an endoscopic revision, so there's no need to go back for a second surgery. The endoscopic sleeve, the wonderful case that he presented with the patient with infertility. This is a revolutionary procedure. Over the last 10 years, we've seen remarkable outcomes in our patients. Again, incisionless all through the mouth, and very low risk and very easy recovery. And then, of course, the balloons are an excellent option as well. Very appealing to patients who just want their stomach to, be the same and really untouched. The balloon is a great, safe thing to do for people that are that have other illnesses like the one he mentioned with heart failure. And so these procedures, these devices, these are all helping not just weight, but also treating all of the comorbid conditions that come with that, things like diabetes and so forth. And there's some other procedures on the horizon that will be coming that we're seeing now. So we really appreciate the opportunity to speak in front of you. You have a wonderful coalition here that can do a lot of things. I think just education and spreading the word that we're doing everything we can to develop innovative, safe, less invasive, and if not non-invasive procedures for what is a terrible and very frustrating disease. And we're here with you, and we're happy to answer any questions that you might have. Thank you guys for your attention. And Andy, really, really nice work, and appreciate always working with you.
Same to you, Mike.
If you found today's Health Talk valuable, we invite you to help us continue providing trusted, science-based education about obesity and health. As we celebrate 20 years of education, advocacy, and support, your generosity helps ensure that we can reach even more people. Visit obesityaction.org/donate to contribute today. Your generosity fuels our mission. Thank you for making a difference.